Welcome back to the deep dive. Today, we're tackling a condition that often gets kind of lost in the shadow of its more famous relative. We're talking about chronic discoid lupus erythematosus, or CDLE. Yeah, you hear lupus, and usually your mind jumps straight to SLE, right?
Yeah.
Systemic lupus erythematosus is the one that can affect, well, pretty much everything. But the sources we're looking at today paint a really different picture for CDLE. It can look similar on the skin, which causes confusion, but fundamentally, it behaves differently. So our mission here is to really pin down what CDLE is, what it looks like clinically, check out its immune fingerprint, and see why it's generally, thankfully, much less systemic.
That's a great goal. And it's so important for people to understand this distinction. The core idea right from the source material is that CDLE is a disease where the problems are primarily and usually only in the skin. Think of it like a localized fire drill, maybe, not the whole building on fire, which SLE can sometimes feel like. The skin signs might mimic SLE, sure, but the sources are pretty clear. Widespread systemic disease is actually rare with CDLE.
Okay, localized, not systemic. Got it. So let's unpack that mimicry bit. If it's stuck on the skin, what are we actually seeing? What makes a doctor look at a patch of skin and think, this could be CDLE?
Well, there are a few classic signs you look for in those chronic plaques. First, you've got some swelling, that's edema, and definite redness, the erythema. Then on the surface, you'll usually see scaliness, kind of flaky.
Okay, swelling, redness, flakes. I mean, that could describe a lot of skin issues, couldn't it? Makes it sound tricky.
It can be initially, but CDLE usually adds a couple more specific and honestly more concerning features because they often point towards permanent changes like scarring versus something called follicular plugging.
Follicular plugging, what's that?
Think of the hair follicles getting clogged up, like tiny drains backing up with skin debris. It gives the lesion a particular look and, yeah, contributes to the scarring later on.
Ah, okay, so it's not just surface stuff, it's getting down into the skin structures.
Exactly. And the second key feature, which is often distressing for the patient, is skin atrophy. The skin actually thins out, wastes away a bit in that area. It's that combination, the inflammation plus this tissue destruction that really flags it as potentially CDLE rather than just, a simple rash.
And sources mention a really specific visual clue too, right? Something about the edge.
Yes, often these plaques have a very distinct edge. It's described as an elevated erythematous border, so like a raised red rim around the main area.
Gotcha, a raised red rim. That gives you a pretty clear target to look for.
That whole picture, the inflammation, the plugged follicles, the atrophy, sometimes that border, that's the clinical fingerprint we're looking for. And seeing that pattern really underscores the main point about CDLE. It usually stays put, right there in the skin.
Right, and you mentioned the risk of it spreading is low.
Very low, relatively speaking. The stats from the source material are pretty reassuring on this. We're talking only about 5% to 10% of patients who might eventually develop some systemic issues. And even in that small group, it often takes years, sometimes many years, for anything systemic to show up.
Wow, 5 to 10%. That is dramatically different from SLE, where you're almost always worried about kidneys, joints, blood cells. So if the risk is that low, what's going on immunologically? Or maybe what isn't going on? Why does the body usually keep this fight confined to the skin in CDLE?
Now we get to the blood tests, and this is where the science really separates CDLE from SLE. It often comes down to which antibodies are present and, crucially, which ones are missing. The sources point to two main markers. First, there are the general anti-nuclear antibodies, ANAs.
Okay, ANAs. Lots of autoimmune conditions have those.
Exactly. And in CDLE, about 35%, maybe a third of patients will test positive for generic ANAs, which, can muddy the waters a bit initially because a positive ANA often makes doctors think autoimmune, maybe even lupus.
Right. So if 1 in 3 people with just the skin disease has a positive ANA, how do you avoid jumping to the conclusion that it's early SLE? What's the tiebreaker?
The tiebreaker is the other antibody, the really critical one. The sources are very clear. Antibodies against double-stranded DNA, the anti-dsDNA antibodies, are rarely present in people with CDLE.
Anti-dsDNA, that's the big one for SLE, isn't it?
It absolutely is. It's considered highly pathogenic, meaning it directly causes damage, and it's a key diagnostic marker for systemic lupus. See, in SLE, these anti-dsDNA antibodies glom onto bits of nuclear material from damaged cells, forming these things called immune complexes. These complexes then circulate all through the blood. and they get trapped in tiny filters, especially in the kidneys, causing inflammation, lupus nephritis. That's a major, major problem in SLE.
Okay, so it's like SLE has these specific smart bombs, the anti-dsDNA, that seek out targets and cause widespread damage, especially in places like the kidneys.
That's a good way to think about it.
And in CDLE, those specific bombs are usually just not being made.
Exactly, or very, very rarely. So without that specific antibody driving the formation of those circulating immune complexes, you just don't get that same level of widespread internal organ attack. The immune system might be overreacting in the skin, yes, but it hasn't launched that particular highly destructive systemic campaign. The lack of anti-dsDNA is probably the single biggest reason why CDLE typically stays localized.
That makes perfect sense. It fundamentally changes the disease's potential.
But wait, didn't we start by saying the skin lesions look similar to SLE skin lesions? Does that mean the local immune reaction in the skin itself shares some features?
It does. And that's quite interesting. Even though the systemic trigger, that anti-dsDNA, is usually absent, if you biopsy a CDLE skin lesion and look at it under the microscope using immunofluorescence.
Immunofluorescence.
Yeah.
That's where they use special stains to see where immune proteins have landed. Precisely. And in CDLE skin biopsies, you typically find deposits of immunoglobulin Ig and also C3, which is part of the complement system, lodged right along the dermoepidermal junction. That's the line where the top layer of skin, the epidermis, meets the deeper layer, the dermis.
Okay, so immune proteins, Ig and C3, are piling up at that junction. Is that what happens in SLE skin lesions too?
Yes. The source material explicitly states this finding is similar to what's seen in the skin involvement of SLE. So it suggests the actual mechanism causing the damage within the skin itself might be quite alike in both conditions. You have immune activation happening locally.
But the key difference is, in CDLE, that local reaction doesn't usually have the backup, the systemic driver, the anti-dsDNA, causing trouble elsewhere.
You've got it. The battle might look similar on the ground in the skin, but in CDLE, it's generally a contained skirmish, not part of a wider war throughout the body.
Okay, I think I'm getting a clear picture now. Let's try to sum this up for everyone listening. CDLE, primarily a skin disease. You're looking for those specific plaques, the redness, swelling, scaling, but also that follicular plugging and skin atrophy, maybe with a raised border, signs of chronic inflammation and scarring.
Correct. And crucially, the risk of it becoming the multi-organ disease we see in SLE is low, only around 5 to 10%, often taking years if it happens at all.
And the reason why it stays local seems to boil down to the immunology, specifically the blood tests.
That's the core of it. While some might have a positive generic ANA, the hallmark of CDLE, immunologically speaking, is the rarity or absence of those anti-dsDNA antibodies.
The antibodies that are so central to the diagnosis and the organ damage in classic SLE.
Exactly. Missing that key player changes everything. And connecting this back, to the bigger picture for clinicians and patients, understanding this difference is huge. It means monitoring can be focused mainly on the skin. You're managing a chronic skin condition, sometimes a challenging one that causes scarring, but you're not usually living under the constant threat of kidney failure or other severe organ damage like you might be with SLE.
That's a profoundly different outlook.
Yeah.
Okay, one last thought to leave folks with. We know from the source material, and generally, that sunlight, UV exposure, can trigger or worsen skin lesions in SLE. The idea is UV damages skin cells, releases nuclear stuff, and the anti-DNA antibodies then react, right?
That's the general mechanism proposed for SLE flares, yes.
So given that CDLE skin lesions also show that local immune stuff happening in the dermoepidermal junction, the I80C3 deposits, could it be that sunlight plays a role in CDLE too, but maybe in a more direct, localized way? Perhaps the UV damage itself is enough to keep that local skin inflammation smoldering in CDLE, even without needing the systemic anti-DFDNA response.
That's a fascinating question. It makes you wonder if, in CDLE, the environmental trigger like UV is interacting more directly with a locally predisposed immune response in the skin, keeping that fire lit just in that spot, without necessarily needing to ignite the whole systemic immune system via anti-dsDNA. It's possible the mechanism is subtly different.
Yeah, is CDLE maybe just a very robust but ultimately contained overreaction to local skin injury like sun exposure, whereas SLE is that plus a catastrophic systemic misfire? Something to definitely think about. Well, that brings us to the end of this deep dive into chronic discoid lupus erythematosus. Thanks for tuning in.